Hello, SYNGAP1. My name is Michael Grally, and this is episode 166 of SYNGAP10, the SYNGAP1 podcast. There's a lot of great news to share today. Talk about stories, episode 32, with our very own CSO, Catherine Heldy. I could talk about the fact we just announced another grant to Dr. Julia Dahlman this morning. I could talk about a lot of things, but I'm not going to. If you remember in episode 164, I asked you to help me talk about unmet need, because there's a company out there who's investing heavily in SYNGAP1, and some of their leadership has asked, are patients, and we know this is a bad disease, but are parents really going to participate in this trial? Are they really going to travel with these kids to take part in an ASO trial? And every time I get this question, I've had this question more than once, I get increasingly exasperated and I pound the table harder and I explain to them, yes, don't worry about it. But they've asked me to come and talk to them about this, and I'm happy to do so. And so what I did is I asked everybody. I asked on our Slack and our leadership, and I asked you on this podcast on episode 164, tell me your unmet needs. Tell me the things that for you are really burdensome and heavy about SYNGAP1. And I got some wonderful slides, and I want to thank everyone who sent me those. And I've been working on this presentation for a few days, and last night I had two epiphanies. The first epiphany was as this list was growing, I was able to put it into three buckets, right? There's a medical bucket, there's a ID behavior bucket, and there's a family bucket, right? And I'm gonna talk about the unmet need in these three things. But I also want to acknowledge that we're not describing the disease here. We're not saying SYNGAP is purple, green, and blue. Epilepsy, ID, and autism, right? We also have GI and sleep and psych and blah, blah, blah. No. That is like the sterile scientific language of medicine, and that is just describing the disease for the publications. I'm not talking about that. I am a patient. I am a caregiver, right? We are patients, and we need to describe our lived experience, and we need to get it through to our clinicians because we need our clinicians. These people are highly trained, good people who are helping us with essential medicines. But they are also overstretched and desensitized. They have patients coming in and complaining all the time. And we come in and we complain because you know what? We don't do a good enough job of complaining. As parents, we are so tired of not getting through to people and of bearing our souls and of talking about our pain that we're like, yeah, it's really hard, blah, blah, blah. And the doctor's like, oh, it's really hard, blah, blah, blah. And then they ignore us. And then we don't get the right solutions for ourselves or our kids. So it's really important. Through going through this, I've really started to appreciate we need to do a better job of explaining the unmet need of SYNGAP1, and they need to do a better job of listening. Because this is a tricky disease. It's slow moving, but it's suddenly changing. And it's absolutely enervating, right? Enervating is much worse than exhausting. Exhausting means, oh, I just ran 5 miles. Enervating means I've been trying to roll a boulder uphill for 20 years and every cell in my body is tired. But let me get to my three buckets. And I'm sharing this with you because I think it's important. I think we need to come around. We need to align as a community in how we talk about the unmet need. I'm not saying you should say what I'm saying. I'm saying here's what I'm thinking right now. Let me know how to make it better. Let's come together and let's use this podcast as a tool to communicate about this important message. But hey, if this works for you, send this to your clinician. Send this to the nurse coordinator. Send this to people. Tell them to listen to it. Tell them that, yes, this is true of my lived experience. Because sometimes it's just hard to find these words. Let's talk about the medical bucket. Existing treatments in polypharmacy. Polypharmacy meaning we're getting multiple drugs, is woefully inadequate and gets worse as patients age, right? So we are facing, not to describe the disease, but to remind ourselves, unrelenting, intractable, and worsening seizures. What does this mean? It means they keep coming. Intractable, you just, no matter how many drugs you throw at them, they somehow overcome the drugs time and again. And worsening, we start 0 to 2 with no seizures, and then we get absent seizures that a bunch of people tell us aren't really seizures, and then we get absent seizures with myoclonia, and then we get convulsive seizures, sometimes we get status, and eventually we get drop seizures. Unrelenting and worsening seizures, and managing those drugs, those seizures that are intractable. So you throw the Keppra at it, you throw the valproic acid at it, then you get upgraded to the Epidiolex and the Onfi. And we have kids on 5 anti-seizure drugs. And then you start changing those drugs. You find a drug that works. Like we have the Ravicti trial right now. We have a number of kids have had seizure frequency has gone to 0 on this drug. Remarkable. But what has happened is we've started taking away drugs because we're like, all right, seizures are down. We can take away these anti-seizure drugs. And interesting things are happening. In some cases, we're taking away the drugs and it's helping the kids a lot. In other cases, we had one kid, we just took him off Onfi. Guess what? He was at 0 seizures before Onfi. He was at 0 seizures after Onfi because of the Ravicti. But his mood went to, and he raged. And it's been really hard on the family, and it's been a crisis. They put him back on Onfi. He's still raging. We've tripped something in that brain. So managing all these drugs just for the seizures is incredibly hard. And then you start realizing, wow, this drug was doing more than fighting seizure. We got Onfi for seizures, but it's actually also managing behavior. We also have to deal with the long-term side effects, right? Valproic acid, there's a black box, there was a boxed warning on this drug. Do not take for more than a year. Causes bone loss. Guess what? Our kids are on it for 1, 2, 3, 5, 10, 20, 40 years. And we now have documented cases, which we've shared in this podcast and on our website, curesyngap1.org/bones. Just go look, right? We had a 20-year-old boy trip on a playground, shattered his leg. We had a 40-year-old boy have a drop seizure, shattered his legs. In both cases, the script was the same. Go to hospital. Doctor looks at x-ray. Doctor looks at patient. Doctor says, this child is not old enough for this fracture to be this bad. I don't understand how these bones broke so much from one fall. Answer? Patient has been on valproic acid for 10, 20 years. So we aren't just dealing with the seizures. We aren't just dealing with the combinations of the drugs. We're now dealing with the long-term side effects of the drugs. And let me tell you something. When your 40-year-old son falls and breaks his legs and is suddenly in a cast for weeks, and now you're dealing with pain meds on top of everything else, that is a massive burden for caregiving teams. Massive. Drug-drug interactions. You're getting drugs from your neurologist. Your neurologist doesn't want to deal with behavior, so they're going to send you to psych. Once you get the psych appointment, your psych's going to give you drugs. They're not going to like each other's drugs. They're going to both want each other to change. They're going to tell you that because they're too busy to talk to each other. Then your primary doc's going to start giving you drugs. And then you're going to go to the collective wisdom of the group, and they're going to be like, well, you got to treat constipation, so make sure you're taking Senna. Now your kid's on drugs from 4 places. No one's looking them all up. And if you're typing in, all these drugs into a DDI, a drug-drug interaction website, it's exhausting. Pro tip, use ChatGPT. Feed the whole list into ChatGPT and say, tell me major drug-drug interactions. Really, really fascinating results. But managing those drug-drug interactions is serious business, right? We know that Epidiolex and Onfi make each other stronger. We know that Tanganil and I think Depakote interfere with each other, so you can't take them together, right? We know that I just yesterday I did this for a patient who was on omeprazole because they thought GERD was an issue. Guess what? Omeprazole was messing with one of their psych drugs. We didn't know that until we typed it in. All these and apparently the psychiatrist who gave them that drug didn't say, tell me all your other drugs. We have to check for interactions. No one's doing that. Don't even get me started on the fact that people aren't doing pharmacogenetics. But that's out of scope for this conversation. And that's just drugs. Let's remember that some of our families are working so hard to help their babies that they're doing the keto diet. The keto diet is great. It is effective. We should all try it when our kids are young. It is really hard. It is a lot of work. It is a lot of money. What about feeding tubes? Some of our kids won't take food, so they're on feeding tubes. That's a whole other level of burden. Running around, making sure you have all the right things to inject into your kid and or making it. Think about every time keeping it clean. Think about bath time. Think about pools. Think about all the work that people with PEGs have to go through, the extra work just to feed their babies. Think about surgical interventions, VNS. A lot of our patients are getting a VNS to manage seizures. Great option. It's been very effective for some. But it's surgery. You're implanting things. You're wrapping a wire around the vagus nerve. The CCs, where we separate the 2 hemispheres. Major operation. Helps with seizure reduction. We have children who have such bad hip issues that they're going to hospitals and they're having major hip operations and they're in casts for weeks. This is the medical burden. This is the unmet need. This is the lived experience of our families dealing with this disease in the absence of a medicine that just goes into the body and makes the body make more SYNGAP. That's what we need. And because we don't have that, we're dealing with everything I just said. All of these drugs being thrown into these beautiful babies and day after day, beating up their little livers. That's just the medical side. Let's talk about behavior and ID. Well documented in the literature that Syngapians have a very strange relationship with pain. The throwaway line is our kids don't even feel pain. That's not entirely true. Our kids have a different relationship with pain. They don't feel pain as much as we do. But when they feel pain, man, they are not liking it. Try taking blood out of a Syngapian. Once that needle gets in where they do feel it, woo! But then what about when they get constipated, right? And this is why I'm always saying manage constipation, manage constipation. Have they pooped today? Take Senna every morning. Because when they get constipated, we just had this with a teenager. In a matter of months, behavior went off the rails. Seizures, terrible. Mom addressed constipation, a lot better. But in those months, it was scary. A 200-pound SYNGAP1 raging, a non-verbal, intellectually disabled patient who can't tell you what hurts, just breaking things in your house. That was what was happening. When he raged, Mom had to hide in her own house until he calmed down. And all we had to do was manage his constipation, and he couldn't tell us my stomach hurts. That's the lived experience. And then what happens when that rage manifests into violence? Do you know how hard it is to love someone and take care of them and protect them when they're biting you and pinching you and kicking you? The only thing harder than that is watch them do it to themselves. Watching beautiful little 5-year-old girls bang their heads against the wall until there's blood coming out of their nose. Watching our kids gnaw on their wrists and their hands because they're so frustrated they have calluses on them. People scratching their own skin. This is what we're seeing. And I'm not talking about people scratching. I'm talking about your son and your daughter, the people you love, who can't tell you why they're mad, but they're hurting themselves to relieve the frustration. That's the unmet need. That's what we have to deal with. That's what happens when you combine intellectual disability, rage, and a strange relationship with pain, blood, and scars. And then you got to send them to school, and school says, well, are you beating up this child? No, they're beating me up. That's always a funny meeting. Let's talk about elopement. Elopement is when patients just bolt, right? Oh, door's open, I'm gone. There are whole discussions on our Facebook group about how you lock a door, how you secure a house, how you build a fence. But these SYNGAPians, man, they're smart. They are the smartest intellectually disabled people you have ever met. When you leave that door unlocked for the first time in 5 months, they will see it and they will be gone. When you leave that window ajar, even though they're in physical therapy and occupational therapy because they have limited fine motor, they will somehow get up that wall and get out that window before you can blink. And then they're going to bolt. And good luck with that, because these kids, intellectually disabled, they don't feel danger. They don't see a street full of cars and say, uh-oh. They say, oh, this will be fun. They don't see a pool or a pond or a puddle and think, I could fall and drown. They just want to jump in it. Who cares they can't swim? Nails, glass, walls, fences, they don't see the danger. They're just eloping. And so as a parent, you got to sleep with one eye open, right? You got to have bars and alarms and bells. And the lengths some of our families have gone to is simply extraordinary. And there's that constant level of background stress. Are they safe? Can I hear them? Is everything secure? Can I take a breath in this moment? That's what's happening. That's the unmet need. And then I'm not even going to go down the ABA rabbit hole other than to say there are a few truly excellent ABA therapists like Elomie in San Diego who know what they're doing and form a strong partnership with families. And the BCBA, the big dog, is so engaged the family gets appropriate level of support. However, in most cases, what happens is you get a BCBA who's covering a lot of families, sending you in RBTs, registered behavioral technicians, who have had maybe a week of training. They are clueless and young, and they have been given a very rigid playbook, and they lack the imagination, the capacity, the training, sometimes the intellect, to understand how to even help you and your kid. And that what they do is they end up parroting rote junk that makes no sense, telling you what to do. Some of our younger families are getting good support from ABA, but a lot of our families find that ABA is simply too rigid to in its current manifestation to grow and support our families. And then you get what is tantamount to victim blaming when the neurologist, my neurologist does this to me, by the way, just so you know. He's like, Mike, you're looking for too many medical solutions. You really got to just work harder on ABA. First of all, don't tell me to work harder. Second of all, no. I have videos of ABA therapists in my home essentially abusing my son by forcing him to do things that he just doesn't want to do. And his spoken language was not there, but his behavior was very clear. Please let me out of my room. And instead, this one RBT locked him down. And when I confronted her BCBA, the BCBA was like, I don't think your family's willing to commit to this process. And basically fired us. I am so mad. KyoCare is the company. KYO Care. Never work with them. Unprofessional, terrible, poorly trained. So ABA, not going to do the trick, guys. Not going to do the trick. Behavior and ID. So we have the medical bucket, we have the behavior and ID bucket, and then let's talk about the family bucket. And I've missed an incredibly important aspect of SYNGAP1 that takes a toll on the kids, but it takes a bigger toll on the family. These babies don't sleep. These babies don't sleep, right? You have to medicate. You have to give them either melatonin or one of their seizure drugs or something. There's rare exceptions who are always interesting, but the vast majority of our kids really eventually stop sleeping around somewhere between when seizures start and 5. Sleep just goes out the window. And you have to struggle to get them to sleep, and you have to struggle to keep them to sleep, right? And what does that mean in real life? What is the reality of that clinical symptom? I just slipped into describing the symptoms instead of talking about the reality. Well, the reality is to calm them down, to soothe them, to get them to sleep after you medicated them. Someone's got to jump in bed and cuddle with them. And that's a weird job description, right? Please come home at 8 o'clock and cuddle with my baby until they fall asleep somewhere between 1 and 5 hours every night. No, people don't sign up for that job. So it ends up being mom or dad. And then if mom or dad is curled up with SYNGAPian, dad or mom, the partner, is in bed trying to recover from the night before when they took the hit. Or maybe they've got a job to do tomorrow and they got to go to work and function like a grown adult. So you get mom and dad not sleeping in the same bed, not cuddling each other, not talking about how was your day, honey, or hey, don't forget to do this morning. Well, all the things normal people do when they sleep next to the person they married. No, we don't get to do that because we're sleeping next to our kids. And if they stay asleep, we at least get to sleep once they do. But sometimes they don't. Sometimes they wake up at 2 a.m. or 3 a.m. And sometimes they start talking and just blah, 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 blah. You're at 3 a.m. You're like, what the hell's going on? And sometimes they start kicking and punching and they're not happy. Or sometimes you got to change a diaper. We're still in diapers. I got to add that to the list. It's no fun changing diapers when they're 1 and 2. It is another level when they're 10 or 11 or 20. Changing diapers, no fun. So sleep affects the whole house. It affects mom and dad's time together. It affects the siblings because these SYNGAPians, they don't just not sleep. They don't have the normal social graces of keeping your mouth shut at 3 a.m. They're blah, 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 top of their voice if they're not screaming or kicking or raging. The exhaustion of the years of the diagnostic testing before diagnosis, and then the fundraising and the clinics and the natural history studies and all the things we're doing. Thank you so much to every parent who is working so hard to help their kids and to help this community in the process. But it takes a toll. Our parents are tired. It is no fun trying to schedule a meeting with psychiatry, talk to your psychiatrist, and take notes fast enough to tell your neurologist what your psychiatrist said because they don't talk to each other. So you're not sleeping. You're exhausted. You have a second job of taking care of your kid. And then, to add insult to injury, you suddenly find yourself in the middle of a divorce. The statistic is that special needs families have a divorce rate of like 80%. And that sounds extraordinary, but then you stop and you look around our community and you realize there's a lot of truly exceptional moms and sometimes dads. It's normally the moms, but sometimes it's the dads, where the spouse just couldn't hang. The spouse ran for the hills. And you're like, who left you? I find myself saying that to myself all the time. Who left this person? What were they thinking? This person is together. This person is smart. This person there's so many reasons. Why would someone get lucky enough to marry this person but then run away? Because their kid had SYNGAP and they couldn't cope, right? The mental health, the tax, the burden on a marriage and on a person when your child has a disease like SYNGAP1 is very significant. And then this poor parent who is barely holding it together, taking care of SYNGAPian, now has to deal with being a single parent taking care of his SYNGAPian. It is no joke. It is no joke. And then you get to this very real feeling, which I can't tell you how many times a parent has looked at me and said, I just can't die. I am the only person who understands my kid and can take care of my kid. The schools can't handle it. The support services can't handle it. ABA was a catastrophe. Who's going to take care of my kid when I die? They're getting bigger than me. They're getting stronger than me. I'm getting worried. I don't know what to do. These are conversations I have every week. So you want to talk about the unmet need, the patient experience? It is a visceral, keep you up at night no matter how tired you are feeling. That you're the only person on this planet who really knows how to take care of this kid. And if you trust them to a system, that system will just end up drugging the hell out of them at best. I don't want to talk about it worst. And shoving them in a corner. It's heartbreaking. But it's a very real feeling. And then I'm going to end on the family token with, the people who pay the price first, but they're the last ones we ever talk about or think about, and that's the siblings. I don't have the time in this podcast to tell you, but in the early years with my two boys, my little man adored his big SYNGAP brother and copied everything he did, and we thought that was the problem. Like, he thinks this is normal. He's running around the house, throwing diapers everywhere, breaking stuff. But now I have a different problem. Now my 6-year-old has figured out his big brother's different. And he looks at me very seriously some morning and says, Dad, have you cured SYNGAP1 yet? Because I don't like this. I want brother to be normal. I want my friends to stop asking. I want to know it's safe to go give my brother a hug. He's not saying that in so many words, but that's what he's saying. The siblings, there's a whole, I would say, underdeveloped and not sufficiently robust, but there's a whole part of psychiatry and counseling for siblings of special needs people. Because the reality that they have to process and the things they have to face early in life are very heavy. And I'm seeing that right now in my 6-year-old boy, and it breaks my heart. So this is the unmet need. Let me wrap this up. There's the medical unmet need, the polypharmacy, the drugs, the surgeries, the doctors, the behavior in the ID, the ABA, the pain, the violence in the home, the elopement, the fear about our loved one's safety and well-being. And then there's the family toll, the sleepless nights, the having an altered reality in your home, the exhaustion, the failed marriages, the feeling like nobody can help and you can't die, and seeing your other kids suffer from this disease as well. This is the unmet need of SYNGAP1, and this is what I will attempt to convey in my meeting with this board. Summary, our patients are complex, increasingly complex. The system isn't working. Families are in crisis, and we need real solutions. So if the question is, are we really going to get on a plane to come and take part in a study? Are we going to do something to actually give our kids a chance to go to the root cause of this problem, make their bodies make more SYNGAP? The answer is hell yes. I didn't even plan this, but yesterday I was on Facebook sort of checking on the community, just seeing what people were talking about. And Virginia shared she's just coming back from CHOP. So Virginia went from Indiana to Philadelphia with Ty. She was patient 100 in the natural history study. Good job, Virginia. Great post on Facebook. I'll share the link. Beata was sharing that she's off to Children's Colorado for the same natural history study. We have different sites, right? We have Philadelphia, Colorado, California through the SYNGAP Promise. Thank you so much, Beata. That's wonderful. We need to use every single spot at Colorado Children's. And hats off to you, Beata, for traveling with Kasha to go do that. At the same time, Corey Bazin, I'm not making this up. This was all on the same day. I'll share the links. Corey Bazin was sharing that she's coming back from New York, where she was taking part in the Ravicti trial at Weill Cornell. Hi, Dr. Grinspan. Amazing work, Corey. Amazing work. And Rainey was taking Beautiful Little Hope to UCSF to do a number of procedures to kind of explore her GI issues right now. And she's just off of a trip to Shriners where they did the hip operation. Poor Hope just got out of a cast, and now I don't even know if she's out of the cast. I'm seeing her tomorrow, I'll tell you. But that's 4 parents on the same day who were all traveling to get better care for their loved ones. That's what SYNGAP parents will do. So please listen to this podcast and get through your heads. Our patients, our families will do anything to give our kids a shot. And we have been waiting and hoping and praying for a medicine that will upregulate SYNGAP for a long time. So when you, company X or Y or Z or whoever, bring those damn ASOs to market, we will be there. We will fill your trial. We will set whatever it is you measure for a successful trial, we will get an A+. Because we have made it this far, and we want our babies to have a better life. And the only way we're going to get there is by upregulating SYNGAP1. Thanks for listening. I really sincerely want your feedback on this podcast. Please feel free to put it in the YouTube notes or send me a message. Have a wonderful week.